Sir, we are live now. With all your permission, sir, I am starting this session for today. Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. A.V. Ramanamurthy, sir. And let me share some of the achievement of sir. Sir has done MBBS, and MS in general surgery, MCH neurosurgery, a neurosurgeon at Apollo Specialty Hospital, Nellore. And today, sir is going to discuss on a topic management and diagnosis of brain tumor on the occasion of World Brain Tumor Day. So, to know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you. Good evening, everybody. I'm Dr. Murthy from Apollo Hospitals Group, Nellore. Today, on the request of IJCP, I would like to present on brain tumors, diagnosis and management. I have little technical issues. Let me try this. Okay, it's good now. Let's proceed. The incidence of brain tumors in India is 5 to 10 per 1 lakh population. It may go up to 12 to 15 in the coming few years, and it accounts to about 2% of all malignancies in the human body. So, when you include all malignancies like colorectal, thyroid, breast, or hematological malignancies, the brain tumors constitute about 2% of all malignancies in the human body, right? So there are two types of brain tumors. One is primary brain tumor, other is secondary brain tumors. And the primary brain tumors are like meningioma, glioma, ependymoma, like that. And excuse me, there is a little technical problem from our side. That ambulance is a direct computer connection Wi-Fi. Wi-Fi to only computer connection. Yes. Okay. The primary brain tumors are meningiomas, gliomas, oligodendrogliomas, glioblastoma multiforme, ependymoma, schwannomas arising from the cranial nerves, the tumors from the choroid plexus like papilloma or carcinoma, or from the 9th and 10th cranial nerve area, that is glomus jugular areas, and from the cellular supracellular area like the craniopharyngioma, pituitary tumors, and from the ectodermal rest like dermoids and epidermoids, and primitive neuroectodermal tissue remnants tumors like medulloblastoma, D nets, and P nets. So there are many to enumerate the primary brain tumors, but all together they constitute a very less number, and when compared to the other systems in the body. So most commonly brain tumors, when there is a space occupying lesion in the brain, the most common tumor is metastatic tumor from elsewhere in the body, like a breast malignancy, colorectal malignancy, or thyroid malignancy, or other malignancies spreading to the lung malignancy spreading to the brain. The ratio of primary versus secondary brain tumors is 1:5. That means for every 6 brain tumors detected, one will be the primary brain tumor, right? The primary brain tumors are more common in female patients, and benign brain tumors are more common in female patients. And in male patients, secondary metastatic brain tumors are more common, and most of the brain tumors in male patients are malignant in nature. So to enumerate like this, primary brain tumors and uh, metastatic brain tumors. So the primary brain tumors arising from the glial tissue, from the meninges, from the primitive neurodermal elements, from the pituitary tumors, from the pineal tumors, and the choroid plexus area. That's already I enumerated. And tumors arising from the cranial nerves, the certain cysts, colloid cysts, arachnoid cysts, dermoids, epidermoids, vascular cysts. These are all embryological in origin, these tumors. And other primary tumors which are locally malignant include cardomas, chondromas, gliosarcomas, sarcomas, chondrosarcoma, rhabdomyosarcoma, etc. And primary central nervous system lymphoma is one separate entity which carries a very good prognosis. And usually brain tumors are graded into low grade and high grade varieties. In the low grade variety, comes under the craniopharyngioma, cardomas, gangliogliomas, gangliocytoma, pilocytocastrytomas. These are curable through surgery, and long-term survival will be very good. Sometimes may require second surgery, second look surgery after a few years or a decade, and it can be cured. And grade 2 are relatively friendly, and expected life expectancy will be more than 15 years. These include pineocytomas, diffuse astrocytomas, poor oligodendrogliomas like that. And the malignant varieties are comes under grade 3 and grade 4. Of all, the glioblastoma multiforme and the medulloblastomas, pineoblastomas are very highly malignant, and the expected life expectancy will be very short, a maximum of 5 years or maximum of 8 years, depending on the IDH positive or IDH negative status on the molecular and immunohistochemistry status. I will come to that later, the molecular profiling of brain tumors and all. I will come to the later in the histopathology part, right? So let's discuss about how to diagnose suspect a brain tumor case. The first and foremost symptom is headache. Heaviness in the head, continuous progressively worsening, and peaks at early in the morning. When the patient lies down, there will be stasis, and it will lead to increased cerebral edema, and because of the low respiratory tidal volume, there will be carbon dioxide retention, and there will be increase in the blood flow to the brain. There will be hyperemia, and in this lying down position, you know very well, against gravity is eliminated, so the tumor volume will increase because of decreased hampered venous data from the tumor. So it will lead to severe headache early in the morning. At the peak of the headache, it will be continued as a projectile vomiting. A huge vomiting will happen, and with the vomiters, patient will have, with the vomiting followed by the vomiting, patient will have relief of his headache and other symptoms also sometimes. So usually the vomiting happens due to stimulation of chemoreceptor trigger zone in the floor of the fourth ventricle, right? So next symptom, the most important symptom is visual symptoms. There will be progressive visual blurring. At the peak of the headache, there will be visual blurring with the double vision light. So patient will appreciate one object as two objects, the double vision will happen, and it's progressively worsening in nature. Visual deterioration happens due to papilledema. So because optic nerve is in direct continuity with the central nervous system, when there is a raised intracranial pressure due to the tumor, the optic nerve suffers, perioptic nerve CSF suffers high pressure, and the exoplasmic flow in the optic nerve will be hampered, leading to visual blurring. So once the vomiting happens, the ICP will come down and patient will have clear vision again. So other symptoms are seizures. Seizures can range from any type. It may be generalized tonic-clonic seizures, or maybe complex partial seizures, motor or sensory type of seizures. Any type can happen. So other symptoms are depending on the location of the tumor, different cranial nerves will be involved. If the tumor is located in the anterocranial fossa, patient will have difficulty in smell, or he cannot smell the, and if you have the tumor is lying on the anticlinal fossa or in the optic nerve area, he will have visual deterioration. Or if the tumor is compressing in the cavernous sinus, where the third, fourth, and sixth cranial nerves, which are responsible for extraocular movements, are there. So extraocular movements of the eyeball, then the patient will suffer squint or diplopia. So if the tumor is sitting on the fifth cranial nerve, patient will have numbness of the face and difficulty in chewing. If the tumor is sitting on the seventh cranial nerve or eighth cranial nerve area, that is called CP angle syndrome, a CP angle tumor, cerebellar point and angle area, patient will have deviation of angle of mouth or difficulty in eye closure, and lower motor neuron type of facial paralysis will be there. And if the patient can also have tinnitus and deafness, if the tumor is in the cerebellopontine angle, and the patient, the tumor is compressing or engulfed in the eighth nerve, or it may be arising from the eighth nerve, like in acoustic schwannoma. If the tumor is compressing low down, coming onto the floor of the occiput, where there is a ninth and tenth cranial nerve, which are responsible and swallowing. So it can cause hoarseness of voice, swallowing difficulty, and nasal regurgitation. Because ninth and tenth cranial nerves maintain the process of deglutition. So if the tumor is compressing the 12th cranial nerve, there will be deviation of a tongue or wasting and thinning of the tongue. So anything can happen. If the tumor is compressing too badly the brainstem, it can result in, if the tumor is compressing too badly the brainstem in the infratemporal compartment or on the motor cortex in the supratemporal compartments, patient can suffer weakness of limbs. It may range from monoparesis to quadriparesis. If it is monoparesis, when the tumor is located very specifically on the parasagitally, lower limb weakness will be there on the opposite side. If the tumor is located occupying whole of the motor area on one side, opposite side weakness will be there. If the tumor is compressing at the foramen magnum, where both the pyramidal tracts come together to exit the foramen magnum, then he may have quadriparesis also. So the paresis can be varied depending on the location of the tumor and the extent of the tumor. So I already mentioned papilledema, CP angle syndrome, facial weakness, slurred speech, and cerebellar signs. If the tumor is compressing cerebellum too much, patient can have cerebellar signs in the form of slurred speech, nystagmus, swaying while walking, incoordination of limbs, truncal ataxia, like that. So how to diagnose? How to diagnose? In suspected case, with this symptom, patient has come to us. How to diagnose the case of brain tumor? So the best and gold standard investigation for a diagnosis or in a suspected case of ICS, well, cerebral brain tumor, is MRI scan. MRI scan is done in different modes. The plain scan is done, T1 weighted, T2 weighted images, like that. There are many sequences in MRI. Diffusion MRI, perfusion MRI, contrast enhanced MRI, MR spectroscopy, MR tractography, functional MRI, MRA, MR angiography, and MR venography. All these are very, very essential, very, very useful in a tumor diagnosis and for planning the tumor surgery and to show how much the tumor has caused damage in the intracranial compartment. Very, very important investigations. So now comes, look at this case. The left side is the CT scan, right side is the MRI scan. You can see in the CT scan, it is a case of recurrent olfactory groove meningioma. It is recurrent repeatedly. The score is very high for this case. So you can see how much infiltration it is there in the MRI very clearly. On the right side images are MRI images. You can see the arterial tree, how good it is maintained, whether it is displaced or not. So MRI gives really very good clue. Look at this picture. This is the contrast MRI scan. This is engulfing the internal carotid artery here. In the middle, there is a black spot here. This is the internal carotid artery, and the tumor is enhancing very well with contrast. This is the midbrain. This is the temporal lobe. This is the right temporal, left temporal lobe. Here you see the circular release. The tumor is engulfing the branches of circular release on the right side. It's completely engulfing the branch of circular release on the right side, right? And here you can see this is the superior sagittal sinus. This is the superior sagittal sinus. The tumor is abutting on the superior sagittal sinus and is infiltrating into the superior sagittal sinus and causing obstruction of the superior sagittal sinus. So there is a venous obstruction with the well-formed collaterals in the anterior. You can see anterior two white arrows where there are well-formed collaterals going to the emissary veins and all. So you can, it was confirmed with a distal subtraction angiography where there is a middle third of the superior sinus is completely blocked. So these investigations really help a lot for the surgeon to plan the excision of the tumor. So MRI. This is another MRI method where the tracks, the motor tracks, sensory tracks, special sensors, tracks for the sensory special sensors, visual operators, the olfactory tracks and all. So when there is a tumor like this, you can see here how the tumor has displaced the tracks. This is the tumor. How the tumor has displaced the tracks, you can see very well clearly. This is the visual tracks, these are the visual tracks. Here also you can see the motor fiber. This is a right sitting on the motor area. And the motor fibers are split on either side of the tumor. Motor fibers are split on either side of the tumor. So you can see very well. In such cases, if you operate, invariably we can tell the patient before surgery itself, it is involving motor area, motor cortex. The motor fibers are all around the lesion. So he may suffer to some extent weakness of limbs. Then he will be mentally prepared. This is the motor area and the premotor area. You can see very well clearly. This MR tractography really helps a lot. In which direction we have to decide whether to go anteriorly, whether to go posteriorly or deeply, how much we have to go. It will really help us because these MR tractographic pictures are fed to a neuronavigation and the navigator will guide us how far we have to go in, how far where we should stop like that. So another method is MR spectroscopy. This MR spectroscopy indicates the chemical nature of the lesion. You know well, lactate is the lactate, N-acetyl aspartate, creatinine, choline, like this. The alanine like this. Alanine-rich tumors are meningiomas, right? Lactate-rich tumors are necrosed high-grade malignancy or a brain abscess. So we can differentiate like that. And NAA, N-acetyl aspartate, is a natural neuronal tissue chemical. If it is choline indicates a cell membrane marker choline. If the choline is more than the NAA and choline creatinine ratio or NAA choline ratio is increased, then it indicates it's a gliomatous tumor, most of the glial organ tumor, right? It's like that MR spectroscopy will teach us the chemical nature of the lesion and it will tell us beforehand itself the most probable histopathological diagnosis can be made. The correlation between the MR spectroscopy and the MRI plane and contrast study, the morphological features on MRI, there is a 90% correlation with the histopathological final reports, right? And their tumor genomics in MRI also is coming up now, and it will definitely improve further and further. IDH mutant genes, I will let you know in coming few slides. IDH mutation, positive, negative, frame shift mutations, other those I will discuss. This is the case functional MRI. Here the functional MRI shows the patient will be lying in the MRI chamber. He will be mumbling, he will be speaking some words. He will be speaking some words. I will be calculating. So when there is he will be calculating. What is this noise? So when there is a speech area or word generation area near to the lesion, in this tumor you can observe carefully. Here I will dissect the tumor only anteriorly. I will not prefer to go posteriorly in this tumor because word generation area is lying right behind the tumor. So I will try to avoid that area so that postoperatively patient won't have any deficits, right? So diagnosis of brain tumors can also be done with a CT scan and CT angiography or CT venography are also helpful in some patients to come to a conclusion of which vessel is supplying it. You can see here, this is a case of AV tumor, AV malformation or a meningioma, highly vascular one. So here you can see the contrast management. You can see the vessel supplying it here. The single vessel is supplying it. When you occlude this vessel, automatically we can definitely occlude the tumor, easily attack the tumor and remove it safely. So all these investigations really help a lot. Now let's come to the management of brain tumors. The brain tumors management is medical management is rarely possible. The surgical management is most common, and chemotherapy also is possible, but not really helpful. So next is radiation therapy. It's really helpful now. The radiation therapy, the paradigm shift in outcomes happened, followed invention of gamma knife radiosurgery, cyberknife radiosurgery, JAPEX, and proton beam therapies. So the main stay of therapies for brain tumors are two: surgical management and radiation therapy. Surgical managements are done by neurosurgeons in a tertiary care setups with all his equipment, armamentarium or vans, whatever you say. And radiation therapy is done under the radiotherapist and a highly sophisticated tertiary care oncology unit, where there is availability of different radiation tools. So let's come to how to plan the surgical management. Most important in surgical management is planning, a thorough understanding of the pathological anatomy of the lesion, and selection of my bands, selection of equipment available in our operation data is bands. So planning is very, very important. If I won't plan properly, post-operatively patient will have severe neurological deficit and handicap. So severe neurological deficits will happen if I fail to plan properly. So it should cause least damage while operating to the normal neuronal structures. To achieve that, we should be more careful, right? So thorough understanding of the pathological anatomy is very, very important. So we have to have a very clear-cut discussion with the team, and sometimes virtual practice methods are also available. If we feed this tumor CT scan or MRI to the workstation, there we can practice virtually also to some extent in the laboratories. And these are available very well in the United States of America and Japan, China, where the resident doctors and the junior consultants are asked to practice mainly first in virtual practice, then go and operate the tumor cases to achieve the best results and the least functional deficits. So select and keep the band steady. So why I said read the imaging properly, because you see the tumor here, it is nearer to the internal carotid artery, very much nearer to the internal carotid artery here, and it is the optic nerves, optic chiasma, and these are the anticellular arteries. So while distinguishing this tumor, I should not damage the optic nerve, or my diathermy or cartilage, bipolar cartilage should not cause any harm to these vessels. My cues are catheter ultrasonic suction aspirator should not cause any damage. My QSR machine or my bipolar cartilage should not cause any damage to these structures. You can see here the tumor lying underneath the basilar artery and abutting onto the tumor is abutting the cavernous sinus with compressing the structures within the cavernous sinus. Sometimes tumors will be infiltrating in the anterocranial fossa, producing the CSF leak postoperatively. So all these challenges can be met if we read the preoperative imaging properly, right? So main thing to remember is while before operating these brain tumors, eloquent areas, non-eloquent areas. Non-eloquent areas are frontopolar areas, temporal polar areas, occipital polar areas, like that, intraventricular lesions, where there is no functional neuronal tissue much there. So if we remove the tumor, In total, along with the surrounding glial tissue also, patient won't have much deficits. Eloquent areas, near eloquent areas means these are penumbrathos. Like the tumor is abutting the motor association cortex, a sensory association cortex, very near to the essential brain centers. Eloquent areas means Wernicke's area, Broca's area, cardiomotor centers, like that. So eloquent areas means cranial nerve nuclei, sympathetic supply nuclei, involuntary functions like breathing and cardiac functions. So if the tumor is involving those areas, those centers, those are called eloquent areas. So we have to first identify whether the tumor is non-eloquent areas or near eloquent areas or in the eloquent areas. Then we have to plan, reduce our aggression of tumor rejection. See this, here you can very see clearly. It is in the brainstem, in the upper midbrain, involving the pons partially. Here it is completely involved in the pons, but it is in the going onto the cerebellar. It is going onto the cerebellar, middle cerebellar peduncle, and on the floor of the fourth ventricle. It is an eloquent area, right? This is frontopolar area, non-eloquent area. So other is the philosophy behind this is the tumor is completely resectable in non-eloquent areas or nearby eloquent areas. Almost 98% we can reject aggressively and surgeon can go enthusiastically. If the tumor is in eloquent area, if surgeon should cut down his surgical enthusiasm. Otherwise, he will end up damaging the patient functionality. So patient may be having normal function before surgery. After surgery, a patient may have deficit in the neurological function, resulting in very bad handicap, like a facial nerve paralysis, or difficulty in swallowing, requiring a right tube or gastrostomy, or difficulty in breathing, resulting in due to lower cranial palsy, so requiring a tracheostomy care. You know the morbidity associated with right tube feeding or gastrostomy feeding and the tracheostomy care. The hospitalization will be prolonged. So if he loses the ability to speech, name the people, identify the people, when the tumor is lying in the Wernicke's area, without proper identification, if the surgeon does the surgery, damaging those areas, Broca's or Wernicke's area, patient will have very bad deficits. It will look very awkward. Before surgery, he was speaking well. After surgery, he is not speaking well. What is the point in removing completely the tumor? There is no point in doing such surgery. So surgeon should plan properly, depending on the functional MRI and the regular anatomical knowledge on MRI scan examination. So what are the VADs? So neurosurgical team includes a lot of expertise, lot of equipment to do a safe neurosurgical practice. Keep apart the trauma surgery, but for a brain tumor surgery, it requires a lot of expertise and lot of technicality is involved in it. We need to use navigation, we need to use microscope, we need to use CUSA like this, and drill high-speed drills and intraoperative angiographies, intraoperative MRI and CT scan, like that, many tools we need to use to have a safer tumor excision. Here you see the navigation. Navigation will show where I am going, whether I am going toward here is a small tumor, right? In a terrain, in a hometown, we don't require it's a familiar terrain. You don't require any navigation to drive in your hometown. But when it comes to a new place, like brain having lodging a small tumor, there you just can't, under the grapes, you just can't go on digging and search for the tumor. It will result in very bad handicap. So navigation will really help. It will show wherever I keep my van, my van will show me where I am. So here you can see I am approaching the tumor here. You can see. In coronal, sagittal, axial plane, in 3 planes, it will show very clearly where the surgical tool is going. That is the advantage of navigation. Right? This is CUSA. This is Caltron ultrasonic suction aspirator. It contains many channels within it. It is like ENT surgeons using microdebrider. We use this fusor for excision of tumors, brain tumors. And this is a high-speed drill we use to open the cranium. Sometimes we use to drill the skull base or the neural foramina or the ostial foramina where the cranial nerves exit to decompress those properly. So these are very, very essential tools. Other important tool is intraoperative neuromonitoring. This is especially used to preserve facial nerve, to preserve facial nerve in cerebellopontine angle tumors and in brainstem gliomas or in the motor area lesions. When you are excising a large lesion lying in the motor area or within the brainstem or nearer to the pons or medulla or within the cerebellopontine angle, we use all these intraoperative neuromonitoring techniques. We need to have a separate neuromonitoring technician also in the operation theater. The neurosurgical operation theater team is a huge team. So it contains a main neurosurgeon, neurotechnician, the technician to arrange all these operative theater technician, apart from the anesthetist and anesthesia technician, scrub nurse, assist nurse, and the floor nurse. So at least 6 to 8 people should be readily available to conduct a classical neurosurgery brain tumor case to do safely, okay, without any compromise in the armamentarium. So this is endoscope. We use endoscope for lesions located within the cavities, and endoscopic transnasal approach for pituitary tumor excision is very, very famous and it's very, very easy. And after invention of this endoscope, through the transnasal approach, we excise the pituitary tumor safely, and by next day evening or within 2 days, patient can go home safely. So neuroendoscopy revolutionized the management of pituitary tumors very well, and also certain tumors in the skull base. Extended skull base surgeries are done with the help of as a team with the ENT surgeons. So, ear, nose, throat surgeons also. They deal with the anterior compartment. We deal with the deeper posterior compartment. And once neuroendoscope is used, it needs a special expertise and it has a long learning curve and separate training for this. So these are all the surgical brands. And sometimes you can observe the last one, awake craniotomies also in the brain surgery. Awake craniotomy is done basically to avoid postoperative neurological deficits. It is done with a neuroleptic analgesia where a patient is draped and he is given anesthesia, draped, he is made to get awake again by cutting down the gases with adequate local infiltration and all. Patient, when we are operating, we ask the patient to see a movie or to make some words or make some sentences, especially when we are operating on the left side of the brain, near the Wernicke's areas or Broca's area or on the motor strip area, where we ask the patient to move his right hand. A clinching movement, a ball is given and is asked to squeeze it continuously, or SOS, whenever the surgeon gets it out, he is going to produce the deficit by removing this part of the tumor, then he will ask the patient to do it. Once I touch that suspected brain tumor part or suspected brain area, he cannot do this. Immediately the deficit will be seen. So this method is used, the awake craniotomy method, to excise the brain tumors is used to reduce the postoperative mortality mainly, right? So exoscope, on-screen observation, endoscope is also on-screen observation. Unlike the microscope, where microscope we see within through our eyes directly and operate, but in exoscope and endoscope we see on the screen and operate like this. So it needs definitely separate training, and intraoperative delivery of radiation is also available in the newer microscopic methods. So tumor PET is given in radiation directly. These are very, very expensive and they have come into practice in the most developed countries like United States of America and Japan and Germany, right? So this is the video picture, how we operate on a case of brain tumor. A short video I will show. This is a suprasellar meningioma. This is a frontal craniotomy we have done. In the frontal craniotomy. Here you can see this is the meningioma. Here is the meningioma tumor. The suprasellar meningioma. This is all tumor. Two frontal lobes are separated, and here with the bipolar I am doing arachnoid dissection, and in between a saline is poured on the brain tumor or a dissection area to avoid damage to the surrounding, making it more, if it becomes dry and sticky, it is difficult to operate. So in between saline is poured on the tissues. Right? This is arachnoid dissection. Slowly arachnoid dissection is done, and two hemispheres are splayed apart, two frontal lobes are splayed apart, and there we can see the meningioma, a very bright red, very red tumor you can see. It is a highly vascular tumor. This is how it's a meningioma base. This is the base of the meningioma. This is all meningioma. So we attack on the base always. This is all meningioma tumor. We always attack on the base. Like the tiger always holds the neck of its prey. Like for any tumor, we have to first cut off its blood supply. Like this, we have cut off the blood supply. The blood supply vessels are coagulated and cut off. Then the tumor will become dumb. It will not bleed. So it will be very easy to remove the tumor then, right? This is how. These are the under the retractors of the frontal lobe. This is the frontal lobe, left and right frontal lobe. At the end of the tumor dissection of the cellular supracell area, we can see the pituitary stalk, optic nerves, internal carotid arteries, everything we can see very clearly. So once the tumor is completely removed. So you see, this is called CUSA. I already said this is done under high magnification, 16 to 24x magnification. We do this. This is the cavitron ultrasonic suction aspirator. This is a wand, a wonderful wand to remove the brain tumors. Right? This is bipolar coagulation of the tumor. All this is tumor. This is our tumor. This is coagulating. Then I am removing with the CUSA. And this is the frontal lobes here. Here the frontal lobes. This is the optic nerve. You can see very clearly. The optic nerve was engulfed on all sides by the tumor. We use carotenoids, and that liquid, the fluid is the cerebrospinal fluid coming in between. That white membrane is the arachnoid layer. This is white membrane is the arachnoid layer. Right? This is all the tumor. This is all tumor. This white layer, this is the solid fleshy tumor you can see. Now I am removing with the tumor holding forceps. Right? We should not pull back. We should do very gently, very gently. Millimeter by millimeter only we have to remove. We should not pull the tumors. There will be no much space. If we pull out the tumor, it will pull out the chiasma and optic nerve also, along with internal carotid artery. So it should be very carefully done. So this is optic nerve, we are dissecting. You can see. And we should be careful by operating on this patient. Okay. Large chunk of tumor is coming out now. Because you see, we always coagulate the base here. Coagulate the base, you are bleeding. The meningiomas are supplied from the dura, highly vascular tumors in the brain. So, the more and more pale it becomes means, I am now coagulating the blood supply of the meningioma here. We cut open that, once we coagulate, we cut it, coagulate and cut it. So base is always attacked first, then followed by removal of the tumor. So now you see the base is empty completely. This is a planum spinae suprasellar meningioma. Alright. Sulcus chiasmaticus we call this area. This is optic nerve right side. This is optic nerve left side. These two are internal carotid arteries. This is right internal carotid artery. This is left internal carotid artery. This is cellar 4. This is pituitary fossa. Where I have kept my cotton is a pituitary fossa. This is the pituitary stalk. You can see very clearly actually. Under that, this is a left internal carotid artery, left optic nerve, right internal carotid artery, right optic nerve. This is the pituitary stalk. You can see the pituitary stalk very clearly. That is the pituitary gland there. There's still arachnoid I have preserved. I have done an extra arachnoidal dissection, completely extra arachnoidal dissection, which is very, very safe to do, right? So this is how we operate on these patients of brain tumors. This is a short video of brain tumor dissection. You can see very clearly, right? So after the brain tumor dissection or removal, what happens? 90 to 95% of the patients recover very well and get back to their original occupation in a month or two, right? And especially for benign tumors, there will not be much discussion, but for malignant tumors, there will be a lot of problems we encounter. So certain brain tumors do well, while others succumb very fast. Why it happens? It may be sometimes we say my glioblastoma multiforme patient is doing well, but other times we say grade 2 glioma itself got rapidly progressed and patient died. What is this paradox? So this paradox was investigated thoroughly by the molecular pathologists and geneticists, and they have identified very clearly certain genetic issues are there in the tumor cells. So analysis and molecular analysis of the brain tumors is very, very essential. Certain brain tumors do well while others succumb fast. So appear very low grade initially for the paradox. So for everything you know well, Modi will not be there. So histopathology alone cannot decide. We regularly submit these pictures. Why this happens? Why this paradox happens? I'll explain now. Histopathology alone cannot decide the outcome, right? Molecular profile alterations of cell will decide the behavior of the tumor. What are these molecular profile alterations? You know well, brain tumor diagnosis is done through microscopic surgery, immunohistochemistry, next generation sequencing, methylation profiling. All last two, the immunohistochemistry, next generation sequencing, methylation profiling are done in a molecular lab. Histopathology is done in a regular medical college or regular hospitals. So we have to send the tissue, preserve the tissue, send it for electron microscopy or a molecular lab carefully. Then only you really get the picture. So molecular profiling or tumor genomic profiling is a form of genetic testing that classifies tumors based on the genetic makeup of cancer cells that decides the biological behavior of the tumors. So classification of brain tumors is not on the morphology, not on the MRI picture, not on the origin cell of origin now actually. It is totally on the molecular genomics. So it helps the treatment planning, it helps the prognostication, it helps for target therapies also because we can tag the antibodies and give to the patient to settle, then it will directly hit the tumor cells only, sparing the normal cells. So treatment planning is done best with molecular genomic profiling of the tumors. So operation done, just leave the patient, follow up with again MRI is not correct. We have to send the tumor specimen for tumor genomic profiling every case. So it will give us the genetic makeup. So there are two mutations, as you know well, in the undergraduate and postgraduate examination, the point mutations and frame shift mutations. The point mutations are very easy to handle and the patients will have wonderful prognosis. The frame shift mutations are very dangerous and the patients will have worse prognosis. So IDH is one enzyme, isocitrate dehydrogenase enzyme gene. If it is positive, it is an enzyme essential for neuronal integrity. If it is positive means patient will have very good prognosis. Negative gliomas, isocitrate dehydrogenase enzyme mutation is not there. Till the tumor happened, that means tumor happened due to frame shift mutation, which are very bad. So if IDH mutation is there, tumor is less malignant or benign. The patient will have very good expanded life. Expected life will be very good. So IDH mutation is there or not is given by the geneticist or molecular pathologist. How it is done? It is done by fragmenting the tissue repeatedly and it is in the DNA lab it is analyzed. DNA fragments are analyzed. So they will give you very clearly IDH mutation positive or negative, like that. Methylation process also they will tell. The so frame shift mutation examples are hypertrophic obstructive cardiomyopathy, cystic fibrosis, Charcot-Marie disease, Tay-Sachs disease. You know well, all these carry very poor prognosis. Like this, if your brain tumor is negative for IDH mutation and positive for frame shift mutations, then the progress is going to be bad. Whatever class you say, it's a grade 1 or grade 2 or grade 3 or grade 4, whatever you say in a regular clinical practice terms, but geneticists or molecular biologists will decide the outcome, right? So, post-operative care, dedicated neurosurgical ICU is very essential. ICP monitoring, continuous monitoring of Glasgow Coma Scale, intraoperative or post-operative bedside EEG is really help to pick up the epileptic activity because sometimes non-convulsive status epilepticus also can happen. A non-convulsive seizure will also be there. So we cannot say patient is drowsy, not responding, but nothing found on the MRI or CT scan. Then EEG will show the subclinical epileptic burst. So if we adjust that antiepileptics, patient will recover immediately. So intra ICU EEG availability is very essential. Intra-arterial blood pressure monitoring, non-invasive blood pressure monitoring is very essential to maintain optimal blood pressures so that mean arterial pressure will be good. If mean arterial pressure is good and mean arterial pressure minus intracranial pressure is equal to cerebral perfusion pressure. So mean arterial pressure is maintained well, ICP is maintained well, then cerebral perfusion pressure will be maintained well. So CPP if it is maintained well, the cerebrum recovers very fast, right? So ETCO2 is another probe and tidal carbon dioxide water. ETCO2 probe really helps a lot, and in the ICU setting, during operator, during the surgery also. If ETCO2 values go up, cerebral edema will worsen, and brain will be very angry. It will be hyperemic. It will be bleeding. So if ETCO2 is maintained optimally, brain will be cool, happily pulsating, and it will be lax and silent. ETC oxygen saturation maintenance is also very essential for long-standing ICU coma patients. DVT stockings and hypothermia prevention with warm-ups is all you know. It's a general ICU care. So addend elevation is mandatory. Mannitol, what are the methods to reduce ICP? Mannitol infusion, 3% saline infusion, oral glycerol solution, tablets like acetylcholine to reduce CSF formation. Dexamethasone, steroids really help to reduce the tumorogenic edema. In brain tumor edema, dexamethasone is a wonderful drug. 8 mg is given 3 times a day in adults. Depending on the body weight, you have to plan. Antiepileptics. Epilepsy prevention is very essential. A single episode of seizure will worsen the intracranial pressure and patient may go into herniations and may develop apnea and die. So antiepileptic measures are very important. Hyperventilation therapy to maintain optimal carbon dioxide levels is very essential. So with all this care patient has come out and he did well. In the next coming 2 to 3 weeks, we refer the patient for chemotherapy and radiotherapy. So chemotherapy and radiotherapy is done by the medical oncologist and radiation oncologist separately. It's a vast topic. Better those people dealt with this. I'll just give outlines. The radiotherapy, as I already told you, radiotherapy and chemotherapy, radiotherapy and surgical therapy has changed the neurosurgical results wonderfully. Apart from the chemotherapy, chemotherapy has not much role, but still it is there some role only. So mainly the surgical therapy followed by radiation therapy. Here you observe we have all these bands. The first is gamma knife surgery. This is gamma knife GKRS, leg scale frame, and the gamma knife radiosurgery. Gamma knife radiosurgery is it's only surgery by word, not really surgery. There is no knife involved in it. With the principle of collimation, all the radiation waves, the rays are focused onto the tumor directly, and the tumor is hit at a time. So the tumor cells will die. The other method is cyber knife surgery, a versatile surgical technique above a gamma knife radiosurgery. This is a recent inclusion in the armamentarium, the JAPEX. JAPEX is a the infrastructure required to build a gamma knife unit or cyber knife unit or proton beam therapy is very high because you need to have atomic research center permissions and all. For JAPEX, you don't require anything. The JAPEX is this mission. This really made a huge difference and revolutionized the brain tumor management. It can be done on outpatient procedure. It costs approximately 8 lakhs and it is now available at Apollo Hospitals, Delhi. So recent inclusion in our armamentarium, where a small tumor, less than 2 centimeter tumors, can be hit with the JAPEX and patient will really have good outcomes. And now 2 patients have to follow who underwent a doctor and another lady, a teacher, who underwent a JAPEX treatment at Delhi recently. They have gone all the way to Delhi and got it done. And it's really good. The results are really good. The future is very promising. So, just to mention for conclusion's sake, brain tumors do happen in the families. They run across the families, but as long as there is no consanguineous marriages, the brain tumor hereditary pattern of brain tumor can be prevented. So nowadays the consanguineous marriages incidence has come down. So brain tumor incidence across the families has also come down. So the neurofibromatosis, tuberous sclerosis, Van Hippel-Lindau syndrome, all these patients can have familial forms of tumors. In neurofibromatosis cases, earlier, 25 years back, my practice started 20 years back. I have removed in a single case, 42 tumors totally. In the brain, 6 tumors. In the spinal cord, cervical spinal cord, thoracic spinal cord, lumbar spinal cord, total 42 tumors I have removed over a span of 3 years. And patient later on survived around 12 to 13 years. Later on, he succumbed to different complications of aspiration pneumonia and all. So neurofibromatosis, there will be a lot of number of tumors. Whenever neurofibromatosis patient comes, we have to do MRI scan of the brain and total spinal cord to pick up the tumors where they are present. So we should be carefully screen such patients. Tuberous sclerosis, subependymal giant cell astrocytomas can happen. So this is to mention the familial things do happen in brain tumors, but the incidence is very less. So I thank the audience very much. I thank the organizers very much for asking me to present on this. Thank one and all. Audio.
No, this was silent.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants who have joined this session.
Okay.
Sir, we have received some question from the participants, sir. If you allow, with all your permission, shall we take these questions?
Please, please.
I can see the first question is from Dr. Agarwal. He is asking what potential future therapies are on the horizon for brain tumor treatment.
Oh. Brain tumor treatment, as I mentioned in my last slides of the talk, if it is diagnosed very early, of course, it's possible to diagnose very early brain tumors because of availability of MRI scans at the nook and corner of each district. So for every patient, whenever he suffers a little amount of headache also, now patients they themselves are opting for MRI scan and early diagnosis was made possible. When the tumor is small in size, 1 to 1.5 centimeters, patient can go for JAPEX treatment. JAPEX or cyber knife or proton beam therapy like treatment, which are JAPEX is especially outpatient therapies, right? And with the invention of neuroendoscopy, we are able to remove the tumors very quick and fast using the neuroendoscopy. And next day or very next day, patient can get discharged within 2 days or 3 days and come back. Intraoperatively, we also now the surgeons are giving radiation therapy in the tumor bed itself, and they're instilling chemotherapy also. Temozolomide patches, temozolomide they are giving, and the glioma patients are really recovering very well. That's it. Thank you.
Thank you so much, sir, for answering this. I hope that Dr. Agarwal have received his answer. Moving forward, we have another question from Dr. Subramaniam. He is asking, how do you approach palliative care and quality of life issues for patients with malignant brain tumors?
That's a good question. But the palliative care in India, we are lacking definitely to say. It is available in major cities only. The palliative care and the post-operative rehabilitation care is available only in major cities. And at district level, definitely we are lacking that care. We need to have a, involvement of the pain specialist in the team also for a good palliative care. And home care services also we have to encourage for a good palliative care to cut down the costs, hospital costs and the burden of the hospitals. Family burden can be reduced. So home visits, home care services, involvement of the pain specialist is very helpful for palliative care.
Thank you so much, sir, for sharing your insight on this question, sir. Moving on, another question is from Dr. Shruti. She's asking, what are the ethical consideration in the brain tumor research and treatment, sir? Could you please share some points?
Brain tumor research, honestly speaking, I have no much idea about this. I'm an active clinical practitioner. I never got involved in research. So I have to go through it. Maybe in the Google, maybe I have to go through it. I'm not, I never focused on the research about this brain tumor. I'm basically a microsurgeon who indulge 24/7 in removal of these tumors and refer them to a radiation oncologist. So I never thought in those lines of ethics of brain tumor management trials and all. I'm sorry.
Thank you so much, sir. Sir, I can see one feedback from Dr. Subramaniam. He is writing wonderful topic and very well explained.
Thank you. Thank you.
Answer one more question I can see in the chat box, sir. The question is, sir, should a screening protocol be initiated for brain tumor based on family history or other risk factors?
Yeah, that's true. That's true. That's true. That is definitely true. If screening should be done, then there is a family history is there. I have few families where mother and son, the father and son, suffered the similar type of tumors and all. So our nephew suffered the similar type of tumor. So definitely it will help. So
Sir, thank you so much, sir. This question was by Dr. Manasvi, and she has asked this question. I hope you are able to solve and solve given the answer, sir. Sir, as I can see, sir, there is no more question from the participants, sir. As I hope you have done justice to this topic, sir, and able to solve all the queries related to this topic. Sir, as there is no more questions, sir, with all your permission, shall we conclude this session for today?
thank you so much.
Welcome, sir, and we would like to see you in future also in collaboration with IGCP with some new topics, new sessions, sir. Till then, take care of yourself.